Welcome. I'm pleased you're able to join us today for the webinar with Barbara Nugent, providing her view on MRI safety from the front line. My name is Colin Robertson. I'm Senior VP with Metrosense, and we're very excited to be hosting this webinar. For those of you less familiar with Metrosense, we're the leading provider of advanced magnetic detection technologies. Our FerroGuard ferromagnetic detection systems are protecting patients and staff now in 36 countries around the world. Before I hand you over to Barbara, I have a few housekeeping items to quickly cover to make sure we all get the most out of our time today. Firstly, today's session will be available on demand after this live version. Just follow the same link as you used just now, which will also be in the email we'll send you after the session. Of course, please feel free to share this with any of your colleagues who are unable to attend today. I would now like to quickly take you through the various parts of the screen you're looking at. Starting on the left side is the Q&A window. We hope you'll have lots of questions today, so please do enter them here. Barbara will be answering them towards the end of the webinar, and if we don't get to your questions today, we'll be sure to follow up afterwards. However, we do get lots of questions asked, so please get yours in as early as possible. Don't leave it till late in the session. The window in the center of the screen is where you'll see the slides throughout the webinar. If you'd like to change the sizes of any of the windows, just use the controls at the top right corner of each window. To hide or re-display any of the individual windows on your screen, just use the buttons at the bottom of the screen. At top right, we're pleased to provide resources that can be downloaded during this webinar. Please make sure you take a look at the infographic highlighting 9 key best practices that could significantly reduce the incidence of MRI-related injuries. The final window, lower right, gives you a brief biography of Barbara Nugent, our speaker today. And this leads me neatly to my final task, to properly introduce our speaker to you. Barbara Nugent is an experienced MRI radiographer based in Edinburgh in Scotland. She was awarded Scottish Radiographer of the Year for a commitment to improving MRI safety in paediatric CT protocols. Barbara formed MRI Safety Matters to help disseminate MRI safety education and to run MRI training events. MRI Safety Matters has run some of the largest MRI safety events in the UK, underlining the demand and need for such education, especially for the staff in the front line, radiographers and technologists. Metrosense, we're very proud to have Barbara join our MRI Safety webinar faculty, and it gives me great pleasure to hand over to her now.
Thank you very much, Colin. I'm very pleased to be given this opportunity to describe from a radiographer's point of view some of the safety issues we face every day as the gatekeepers of MRI safety. As the public face of MRI units, treating patients, visitors and non-MRI staff, very few outside of MRI are aware, it seems, of the huge responsibility that falls on radiographers and technologists in keeping everyone safe from harm. I know just what a battle it can be, and I'll suggest some solutions to help to bring home the everyday dangers that we frontline staff face. I'm going to focus on 5 aspects of concern. I'll show the need and desire for standardised MRI safety education from frontline staff. I'll show how we can't rely on MRI incident statistics to accurately reflect the number of adverse events occurring because we're not reporting all the incidents, and I'll suggest some reasons for this. Clarity over incident statistics is hindered by the lack of an appropriate generic reporting system. So I'll briefly show a simple system which has been developed and, if replicated, might help to divulge more accurate statistics and trends. Part of my evidence describes a pilot safety module that was developed focusing on MRI general anaesthetic sessions, because as a paediatric MRI lead, I was aware that this was an area which was poorly served in terms of process. I sought best practice from around the UK, and evaluation of this pilot module highlighted that the checking processes for dealing with these sessions was greatly appreciated, and so I will introduce very briefly a suggested general anaesthetic patient safety pathway. Finally, the need for a ferrous-free culture will be highlighted, with emphasis placed on how the human factor of forgetfulness can be catastrophic for everyone at the front line of an MRI scanner, and how this may be potentially compensated for using better design and tools to help to try to mitigate this all too common human failing. Our guidelines in the UK are the MHRA, and you'll find the links to various references I mentioned in the resource section. The guidelines state that a member of staff is only MR authorised, meaning considered to be able to work safely in the MRI unit under specified conditions, when they've completed appropriate MRI safety training. But there's currently no standardised, accredited or recognised MRI safety resource available in the UK. I needed to know if staff felt that MRI safety is compromised without standardised safety education. Incident statistics didn't indicate that MRI was a modality with many incidents, as national stats from the MHRA will show shortly. So compared to other areas in healthcare, such as trips and slips, which are regularly reported and acted upon, MRI safety concerns seem to be under the radar as far as the need for change is concerned. To find out what MRI staff feel about the current situation, an anonymous questionnaire was sent out. I received over 100 responses from predominantly MR radiographers. 70% revealed that over the previous 5 years, they had witnessed MRI safety incidents which could have or had impacted on patient or staff safety, with up to 65% stating that a lack of MRI safety knowledge was definitely or likely a factor in incidents occurring, with another 20% undecided. This large number of incidents was not evident from the official reports, but it was also revealed that potentially up to 80% of the incidents were also not reported to the MHRA. The next two slides show some of the projectiles ending up in the scan room as witnessed by the respondents. Without the evidence of an issue, there appears to be no issue to resolve, but here was evidence stating that incidents had occurred. As an experienced MR radiographer, the number of ferromagnetic objects that ended up in the scan room did not surprise me. Over the years, I have seen staff, often non-core MRI staff, patients and visitors, attempt to take in such objects and sometimes succeed. Phones, coins, keys, pens, hairpins, scissors, even the odd walking stick, laryngoscope and screwdriver. They're not as unusual as we may think. Each has a story of its own, of course, but crucially, I believe that it's often by the radiographer's quick thinking and a great deal of good fortune that no one appears yet in the UK to have lost their life to the missile effect. Only 10% of reports globally are estimated to be from the projectile effect. Now, this isn't to say that the projectile effect doesn't happen more often, as indicated in the survey, it just doesn't get reported so much, likely only when someone has been injured or the equipment has been damaged. Many reasons were suggested for such incidents occurring: the lack of importance given to changing patients' clothing, for example, and the clinical pressures which impinge on maintaining robust safety practices. The perceived extra risks involved when non-dedicated MRI staff rotate through MRI were also highlighted. From the results, it was clear that safety had been compromised by projectile incidents, but there were also concerns raised about patient burns, checking procedures and policies not adhered to or not clear, where patients had been scanned inadvertently with MR unsafe pacemakers and aneurysm clips, and where insulin pumps had been missed pre-screening. The fact that almost 70% of respondents took the time to make additional comments on what they thought was wrong with safety suggested that staff were heavily invested in the subject, and the comments revealed a great depth of feeling. Comments implied that there was a general lack of knowledge of the risks and hazards, and there was an overwhelming belief that introducing standardised MRI safety education would positively influence MRI safety practice, with 90% support for this. The lack of adequate referral information from referrers also indicated that this group of staff needed an educational resource too. The mechanism of how patient burns occur appears to be poorly understood. This could explain why burns appear to make up the greatest number of MRI-reported injuries globally. It's been estimated that they make up to about 70% of recorded adverse events to MRI patients. The most reported MRI adverse event in England is due to burns. Burns are frequently not sensed immediately by the patient. It's a sort of slow burn effect, so typically the patient can't always warn us prior to thermal damage, which makes it more problematic to prevent. As expected, though, it's the most vulnerable which are at greatest risk, such as paediatric patients, those with learning difficulties, or those under anaesthesia who can't tell us if something is wrong. We need to understand how the frequency fields used in MRI create thermal heating to avoid heat stress, induced current burns, and contact burns. This means learning how to position patients properly and to learn about the scanner's heating capacity. In this example from the UK, the surface coils were not placed over the lower legs, and yet a contact burn occurred there. Because skin-to-skin contact created a conductive loop, there was no padding. This is so easy to get it wrong. Now we come to the first of 3 poll questions. How do you think that introducing standardised MRI safety education for MRI staff would influence MRI safety practice? Would it improve practice significantly? Would it improve practice a little? Or would it make no change to practice? Please select an option and click Submit. And here are the results of the first poll question. Thanks for your input, and hopefully we'll have time to go over this a little bit at the end at the Q&A. Following the research findings, I was able to create a pilot MRI safety module in collaboration with the newly formed UK MRI Special Interest Group. With the most vulnerable at greatest risk within MRI units, as stated, I felt that a module concentrating on how to deal with general anaesthetic sessions would be of benefit, especially with the number of non-core MRI personnel present during such sessions, and the fact that the survey results underlined that such staff were considered an inherent risk. The module was then evaluated with over 90 evaluations returned. Over 90% said it will improve the safety for the anaesthetic team. Almost 90% consider e-learning to be the most appropriate way to disseminate standardised MRI safety education, although it's recognised that classroom-style teaching is very beneficial and the gold standard because you can ask immediately any questions. One of the benefits of an online module, though, is that staff can dip in and out for information, which more than 80% said they're likely to do. And 80% also said the content contained new learning for them. This indicated the need for such a resource, with more than 50% saying that they feel more confident now dealing with safety during MRI sessions. Over 75% think this learning will improve their working practice, saying it will improve the safety for the patient, for other staff they work with, and their own safety. So a single module has been shown to increase confidence in safe working practices, and now a suite of safety modules are planned. There was huge support for further modules tackling all aspects of MRI safety to be developed. Here are some of the benefits to their working practice that they believe undertaking this single module has made. Now, I don't consider that UK MRI safety concerns are any different from those of MRI staff in any other country. Imagine then a comprehensive resource which is developed, which is freely available to all MRI staff wherever they work. And now imagine similar results of this evaluation repeated. It could only help to benefit the patient and all who work in MRI, helping to prevent those all too unnecessary adverse events caused by a dearth of MRI safety education. Another significant aspect of the surveys was that 99% of respondents said that staff needed to have MRI safety knowledge. 70% favoured local on-site training plus an accredited online course. Over 80% said that if such an educational resource existed, that it should become mandatory for MRI staff to complete it. So we've gone from having no concept over whether standardisation of MRI safety education was needed or required by the workforce, to overwhelming support for a suite of modules to be made. And when it is, we only want to work with colleagues who have this knowledge. This makes complete sense, doesn't it? Why would we ever choose to work with anyone who does not understand all the risks? Why would we ever want to compromise our own or anyone else's safety by working with such people if we can educate them? What better way than an accredited course which is role-based, aimed at all who either work in or have dealings with an MRI unit? Then we could perhaps make the case for the need to make such education mandatory and ensure that such staff knowledge is kept updated annually. Without the safety incident statistics to back us up, we may have to rely on reports such as this to force the case for change. Incidents occur that do not get reported, especially near misses. It's not mandatory to report incidents, it's only a recommendation. So is it any wonder that the number of projectiles reported annually to the MHRA are so low? The survey alone indicated a far greater number of projectiles occurred than can be seen here. According to these official reports, only 8 projectiles occurred across the whole of the UK last year. I think this is indicative of a lack of a robust reporting culture. Almost 70% of staff surveyed do not know how, why or where to report near misses, yet this is surely a vital element of improving safety. With no baseline of the nearly adverse events, how do we learn from them to prevent them happening again and again? We have a professional and ethical need to report all incidents, but time pressures and workplace culture can hinder this. However, if we don't report more, how can our concerns be addressed? With no baseline to work from, trends can rarely be identified, and how can we know if there's any improvement? How about US incident reports? Are they any better? Well, looking at this graph, apparently the US reporting culture is even worse. With so many more scanners, MRI scans, patients, staff, it's difficult to fathom how the number of incidents that occur are so much less. Again, I think this highlights how poor the US reporting culture is too. Here's a graph showing the number of burns reported in the UK over the same time period as the projectile records. You can see that there are a greater number of reports than projectiles, but perhaps not as large a difference as previous estimates suggest there should be. I think this indicates just how difficult it is to estimate how many and what type of MRI incidents occur, especially when we know that not all incidents are being reported. Reports and the statistics are at best ambiguous. I think we can safely say that incidents are underreported. Perhaps only 1 to 10% are ever accounted for. We know that incidents occur in which people have been killed and injured. This is preventable, but potentially changes to improve the situation might only occur if the incident statistics indicate that there's a problem, and currently they do not. However, apart from woeful reporting rates, the problem is exacerbated by reporting systems sometimes not being fit for purpose. If the categories are inappropriate for the type of incidents that occur in MRI, it makes it even more difficult to identify trends. To improve this, the Scottish MRI Lead Radiographers Group have developed a new categorisation system. Perhaps if this simple table of definitions were to be spread wider, it might help to simplify and clarify incident statistics. It's very simple, and I would urge you to share it with your incident data managers to see if they would find it useful. The Scottish Incident Reporting Centre are also now developing a trending system so that every incident is visible on a chart over the previous 2 years. This means that people can see for themselves what's being reported. We will see the equipment category along with the suspected problem and, most importantly perhaps, the health impact. We're keen to hear what anyone thinks of all this because it's not mandatory to report, and anything that encourages us to do so can surely only be a good thing. And why is it not mandatory to report incidents where safety is compromised? 75% of respondents supported calls for it, but reporting incidents is only a recommendation for users. Many incidents are never reported unless an injury or damage to equipment has occurred, and many appear to not know to report near misses or good catches. So potentially, the same incidents are recurring again and again, and no one learns from them. It's often compulsory for manufacturers to report, but not for users. Some reasons for not reporting incidents were given: a lack of knowledge on the importance of reporting, what should be reported and to whom. 20% of respondents not even aware that any incidents should be reported to the MHRA, and some not knowing what the MHRA is in the first place. I believe that staff are also not aware that in Scotland, Northern Ireland and Wales, there is a National Incident Reporting Investigation Centre where all MRI reports should be initially sent before being collated by the MHRA. This little detail, showing the apparent invisibility of reporting centres, highlights how little we are all aware of the important processes to follow. MRI reports have up until now been largely inconsequential due to the relatively low number of reports, and in talks with managers, it was clear that MRI incidents do not feature in their must-do tasks where many reported incidents from other areas of healthcare feature and those get acted upon. Once again, if incidents do not get reported, and we know they are happening, then incident reporting centres can't help to promote better safety conditions. And now for the second poll question. How often would near misses or good catches, where an incident, for example, has occurred in the scan room but caused no injury or damage, get reported? Would it always get reported? Would it almost always get reported? Would it almost never get reported? Or would it never get reported? And here are the results of the second poll question. I'm now going to introduce a suggested general anaesthetic, MRI, patient safety pathway. Each unit should develop their own protocols for dealing with anaesthetic cases. However, in the absence of those and for departments considering introducing anaesthetic sessions, this is a robust system of pauses and checks to promote a safe work practice, which could help to formulate your own processes. There are at least 3 pauses for checks to be performed in the patient's journey from arriving at the unit to leaving again. It's vital that stops are purposely made and recorded for appropriate and sufficient safety checks and debriefs to be made on the patient, staff and equipment before the anaesthetised patient enters or leaves the scan room. The first pause involves deciding on the patient order with the anaesthetic team. Any extra procedures to be performed under the same anaesthesia are discussed, for example, taking bloods or undertaking a lumbar puncture. Extra information from the radiographer's point of view, such as administering pumped contrast to the patient or breath hold requirements, should also be mentioned. In this first safety pause, it's essential to confirm an accurate medical history on the patient before they're allowed entry to the unit, to ensure that the patient satisfies all the MRI safety conditions required. When the patient arrives, their ID, examination details, consent and exam requirements are checked and discussed, and visual and verbal checks are performed on everyone to ensure that no one enters the unit with, for example, an MR unsafe implant. Only an experienced MR authorised person should review the screening form with the patient, parent or guardian and sign it with this consenting adult. Attention must now be placed on ensuring that a second pause is introduced into the patient's journey prior to entering the scan room. At this stop, MRI and anaesthetic staff double-check that all safety issues are addressed with the patient or patient's carer before they are anaesthetised, and involves rechecking what has been checked at the first pause outside the controlled access area. Before entry to the scan room, any MR monitoring and ancillary equipment are confirmed as MR conditional or changed to be so. When the patient is anaesthetised, final checks are now made on the patient and their clothing. Meticulous checking of the MR conditional trolley is performed to ensure that there are no contraindicated objects under the patient, under the top sheet of the trolley, or attached to or under the trolley. Likewise, visual checks of what staff have on them are essential too, to ensure they have not forgotten about something contraindicated. Everyone is checked by MRI staff to ensure they are not taking in anything MR unsafe. Every item entering the scan room must be checked and, of course, safety labelled appropriately. The second pause should be recorded before the now unconscious patient is about to be moved into the scan room. Finally, the MRI radiographer, taking responsibility for the patient's safety, checks themselves before entering with the patient and permitting the team into the scan room. A third pause is introduced before entering the scan room again to remove the patient. This is another check, both visual and verbal, of all the staff entering the scan room to ensure that no one has put anything ferromagnetic back on their person or into their pockets before opening the scan room door. Staff can then safely enter and remove the patient. If at any stage of the checks and pauses an incident occurs, it must be reported. This pause may need to be introduced several times, with vigilance required at each stage. summarise this pathway, it's a system of double checks with the anaesthetic team and pauses designed to ensure that MRI staff are confident that all safety precautions have been performed and that they are given the time to do so. Here's a couple of real examples where, if the trolley had not been thoroughly checked, both the suction machine, seen on the right, and the battery charger on the left would have been missed with the cot sides down. They were placed there and subsequently forgotten about by ward and anaesthetic staff when transferring the patient. They had just discovered a very handy shelf under the MR conditional trolley. The importance of patient checks are sadly seen here, where the results of inadequate checking procedures had missed the MR unsafe saturation monitoring on this 6-week-old baby's arm under anaesthesia. Following the MRI scan, the baby's arm had to be amputated due to the burns caused by the MR unsafe equipment. Having a robust checking process with pauses and debrief should hopefully help to stop such incidents occurring. From the evaluation, the benefits of learning about how to deal with anaesthetic sessions was appreciated and indicated that having this knowledge is absolutely essential to improve practice and safety generally during such sessions. This final section looks at the need for a ferrous-free culture in MRI. We know that MRI safety is not all about preventing ferrous items from reaching the scan room, but projectile incidents do not seem to be reducing. What else can we do? Ferrous items will continue to get into scan rooms because people are forgetful, sometimes neglectful, and in some cases are just not aware that they're even carrying a ferrous object. I know of incidents where a child has hidden a battery in his pocket and another a coin in his cuff, just to see what might happen in a scan room. The battery was detected, the coin was not. You might say that changing them into pocketless scrubs would help. It would. But it still didn't detect the ferrous pen that an operating department assistant placed on the inside of his scrub top. In such cases, disaster was only averted by good luck. It seems that warning signs and posters are not always enough to prevent anyone taking a ferrous object into the scan room, or to remind them of an implant. You can have flashing lights, contour plots showing the projectile zone, or colourful posters. None of them are sufficient in themselves to stop incidents from occurring. They are largely ineffective. We may read a poster once, even find it interesting, and then we can promptly forget all about its message. We need every type of barrier in place to remind everyone how entering a scan room can be dangerous. Warning signs alone are just ineffective. We need more than visual aids. We need the human factors involved in incidents to be analysed and then acted upon. It takes but a moment for someone to be in the path of a ferromagnetic item in a scan room, and it changes their life forever. I'm very grateful to the person who let me show what happened to them when they happened to just be in the wrong place and at the wrong time. This is a horrific incident, and there were posters and reminders not to have anything ferromagnetic in the scan room. However, we are all only human, and this trolley was forgotten about by everyone. It can happen to anyone, and we do need every weapon at our disposal to protect ourselves and anyone else in the scan room. We need to ensure a ferrous-free culture above all else. A simple thing which would reduce many projectile incidents, I'm sure, would be to remove all pockets from MRI staff uniforms. We just don't need them, and they have been implicated in many adverse events. What's wrong with a polo top and pocketless trousers, or any uniform without pockets? For staff who have to enter the scan room occasionally, such as anaesthetic staff, we can either ask them to change to pocketless scrubs, or cut their pockets off, or tape up their pockets. Okay, it might not make us very popular with non-MRI staff, but it will underline that MRI radiographers and technicians have the authority in MRI to either permit or not permit anyone to enter the scan room, because they are ultimately responsible for this front line. Maybe a ferrous-free culture with appropriate ferrous-free equipment could mitigate some of the risks. We forget items, we don't know about items, So perhaps we need tools to help to compensate for our forgetfulness. If that means having ferromagnetic detectors which would alert us to hidden ferrous items, would that not be a good thing? I think they can only be of most use, though, if there's a concerted effort by all of us to ensure a ferrous-free work ethos, where we are made to change to ferrous-free apparel, where even our glasses, footwear and underwear are ferrous-free. After all, if we go to a surgical theatre, we're asked to change to protect the patient. In MRI, by changing to a ferrous-free uniform, protects not only the patient, but everyone in the scan room. I know this adds time to everyone's day, and work pressures to get through the lists in MRI is relentless. But that's why the extra effort and time is needed to be ferrous-free and to use detectors sensibly, because pressure and speed cause incidents, and stopping to pause and check creates safety stops. MR conditional trolleys and wheelchairs, of course, need to be designed to be completely ferrous-free too, with absolutely no ferrous parts. Otherwise, staff may become complacent as the detector alarms on yet another false positive item. Analysis of the working practices in the MRI is long overdue, and I'm pleased to say that the first ergonomic assessment is about to be published. This highlights what a complex and demanding work system MRI units are, and that good design, education, and appropriate barriers and checklists are required to help to mitigate all potential mishaps. And there are many reported adverse events caused by unknown ferrous items. Maybe detectors could have helped to identify the 11 ingested batteries within the 5-year-old boy who swallowed them, so that he would never have been referred for the MRI scan, which subsequently perforated his intestine. Now, I'm not entirely convinced that ferromagnetic detectors would have been able to alert staff to these tiny batteries, but at the very least, every appropriate effort would have been made to try to ensure that there was nothing contraindicated. I'm pretty sure that detectors would most certainly have been able to identify the 7-inch ferromagnetic forceps that the surgical team sadly forgot to remove from a woman's abdomen post-gallbladder surgery. In extreme pain, she was referred post-surgery for an MRI scan. She subsequently suffered much more pain as the forceps were being pulled through her abdomen. And now for your help in the final poll question. Over the last 12 months, have you ever witnessed a ferrous item being taken into the scan room by mistake? Yes, more than 10 times. Yes, 5 to 10 times. Yes, 1 to 5 times. Or no, you haven't witnessed a ferrous item over the last 12 months going into the scan room. And here are your responses to that question over the ferrous items. This image, I think, sums up how no one ever sets out to cause an accident. Every care but one looks to have been taken to ensure that the patient will be comfortable for their scan. A soft blanket to lie on, a comfortable knee rest, and a chair for any carer or assistant, only to have an MR unsafe wheelchair spoil the whole experience. I always think when I see images of wheelchairs or any other ferromagnetic objects stuck to a scanner like this, where was the patient during the incident and where was the radiographer? We should not be put in a position where every effort has not been made to ensure that we, our patients and our colleagues are kept safe. I would encourage everyone who has a lead role in MRI to develop regional collaborative groups to discuss all the issues and to help to standardise safety processes, because it seems that we all have the same concerns. We now have an MRI radiographers group in Scotland and the north of England, as well as a Scottish MRI physicists group. NHS National Education for Scotland patient safety managers and incident reporting managers, along with human factors experts, are starting to work together for the common good in MRI safety. We can only improve things by speaking to each other and ensuring that frontline staff, and especially the views of MRI radiographers and technologists, are listened to and acted upon when departments are designed and processes suggested. We do need a wealth of experience and different skill sets from many professionals to make an impact on MRI safety. Networks and good collaboration may be the key to change. To conclude, minimum standards of MRI safety education are needed and wanted by frontline staff, and for it to be targeted at anyone involved with MRI. Education alone, of course, will not eradicate all the risks and hazards, but it will help to cut the human and financial costs of an incident occurring. If healthcare leaders think that education is expensive, they should, of course, consider what the price of ignorance is when a serious incident occurs. With more scanners, the likelihood of adverse events increases, and the human factor is implicit in all incidents. We need good design of departments with every barrier in place to try to prevent incidents from occurring. The operational systems we have in place for checklists, process and reporting would benefit from much greater scrutiny. The momentum for change in MRI safety thinking seems to be here, and we, as a profession, can be the drivers to influence policy, so that the importance of MRI safety is recognised, as are the often heroic efforts that MRI radiographers and technologists make every day in order to keep everyone safe. Finally, I will leave you with this. I believe that MRI is a high-risk industry, and that frontline MRI radiographers and technologists know this more than any other staff. Why then, in 2019, are we still having to debate the safest clothing to wear and the processes to follow in an industry serving the public where hidden items can so easily kill? The onus of safety is put on the radiographer and technologist, but who really looks out for them? We need leaders to insist on MRI safety education for staff and to analyse the best MRI safety systems out there to ensure that every effort is made to keep everyone safe. Let's not make the mistake of improving safety only when another terrible incident occurs. Thank you very much for listening.
Many thanks, Barbara, for that illuminating session.
Thank you.
Before we move on to the Q&A, I just want to ensure that everyone has noticed the resources area at the top right of your screen. Please do review the resources available. A couple I'd like to highlight in particular: the valuable infographic that highlights a number of simple risk mitigation factors that address the most frequently reported MRI adverse incidents, as Barbara's just been talking about. And secondly, for those of you who weren't able to join the MRI safety session with Dr. Canal that Barbara organised in Edinburgh last October, the videos of the sessions are now available online. And finally, if you haven't visited already, please do visit the MetroSense Resource Centre, which contains lots of additional MRI safety resources. So we've had a steady stream of questions coming in over the past 20-30 minutes or so. If you haven't asked yours, then please do so now. And if we don't manage to get to it during this live session, we'll be sure to follow up after. Now, we've got time to answer some of the questions, so let's start with this one. Barbara, are multiple stents safe to scan?
Really good question, and you were often asked that, actually. I would say it depends where they are. If they're in a long vessel and there's multiple stents, their length should be added together because you want to find out what their resonant length is. Now, bearing in mind that the resonant length is halved as the field strength is doubled, so something that was safe at a 1.5 Tesla might not be safe at 3 Tesla. So for multiple stents, it may be that you have to add the length of the stents together. But this is where, if you have access to an MR safety expert physicist, that would be very useful because you could actually get them to measure it for you and ensure that it is safe to scan.
Thank you. Next one. You mentioned how workplace culture can hinder safety. What did you mean by that?
Well, workplace culture can mean many things. If we take, for example, performing all the checks and processes in your department, they might not always be based on best practice. It's just that over the years they've evolved the way they have. So it might be that they've not always been kept up to date as technology evolves. So your screening questionnaire might not be as comprehensive as it could be. You might not have correct implant policies, coronary stent implants, policies, that sort of thing. Some departments, for example, I know they don't actually ask about if the patient has drug or pain relief patches. And even if they ask them, they don't insist that if the patient has them, that they remove the patches. So if the patient, did get a drug overdose or was burned by maybe a metal foil-backed patch, you have to ask, well, who would be to blame? It would probably be the scanning radiographer, because they should know that that is a potential danger, but they've chosen to follow their workplace culture of not removing it, maybe because the patient could complain. So it's just important that we follow best practice at all times. I've got another example which didn't happen in the UK, but a member of staff was pressurised into scanning a patient with an implant. She considered the implant unsafe, but she was told by the supervising radiologist, because they were really pushed for time, just to scan the patient. Now, thankfully, the patient was okay, but at the end of the day, the patient could have been hurt, and the radiographer could have been struck off. So it's really just about dealing with the best systems in place, looking up the best systems that you can find, and following the best knowledge that you can find as well. So following best practice is really what we recommend, but we can understand that workplace culture, peers, supervisors can put unnecessary pressures on staff so that you're not always following the safest practice possible.
Thank you. How exactly can good design of departments help to improve safety?
Well, good design, it's something that they've not really looked at. As I say, I'm happy that we've done the first ergonomic assessment of a couple of MRI units in the UK to see how good design affects how we all work safely or not. An example I've got is, we call it a controlled access area, or zone 3, I think, in the States. But it should just be that. It should be a controlled access area. It should be an area where staff actually have the ability to see who enters and controls the entry point all the time. So keeping the key in the controlled access area only for MR authorised staff is obviously, that's what should happen. But there's lots of examples where various people are just allowed to enter into scanning areas. So that's not a good design. Having obvious barriers in place as well, so that you have to stop and pause before you go into the scan room or into the controlled area. Maybe physical prompts, visual prompts, perhaps detectors if you are going to go down a Ferris-free philosophy. And most importantly, I would say, having worked in a joint control room with CT, having as few distractions as possible. Again, the design when you have a joint control room, whether it's 2 MR scanners back to back or MR and CT, it can make it really difficult because there's so many distractions for staff, and a lot more staff, especially for CT if an emergency patient arrives. Emergency staff might insist on being in the control room or the joint controlled access area. If you had good design and you had radiographers at the beginning designing departments as well, or being involved in that with safety experts, then hopefully we could get designs in place that work for everyone.
Thanks, Barbara. The next question, I think there are lots and lots of similar questions to this one. We could never ask visiting staff to get changed before coming into the scan room. They just wouldn't do it. What do you suggest we say to make them change?
By visiting staff, that's potentially, I could imagine people asking that question, it's maybe senior staff, consultants, that sort of thing, or anaesthetists, where they come in their scrubs with pockets and, why should they get changed? But I think this is where the authority of the MR radiographer has to be made. They should be asked very nicely, of course, that if they want to get their patient scanned, they either have to get changed or, there's going to be a delay. We obviously need good risk assessments and good operating department policies and training processes, but we just have to make sure that all the hospital staff know that the role of the radiographer is to keep them and the patients safe, because staff that come along who refuse to get changed, that implies that they're not on board with all the safety concerns and they've not been educated enough into how important it is to be safe. And anaesthetists, I'm not targeting anaesthetists, it's just that on the whole, anaesthetists and theatre staff are often the most common staff that end up in scan rooms, working in scan rooms. And they tend to be anaesthetic safety focused, as you would expect, but sometimes that can be to the detriment of being MR safety focused because they're not so familiar. And I think it really just comes down to the authority of the MR radiographer. It's our responsibility ultimately to ensure that we can keep everyone in that scan room safe. And we have to have the confidence that we have checked everybody and that we have insisted, if the policy is that they get changed, that they do get changed.
Thanks very much, Barbara. Can I let me just add one thing onto that, if I may, which is, and this is talking now as MetraSense, but one of the bits of feedback we often get from our customers is that actually having a ferromagnetic detection system often acts as a prompt to enable a radiographer to raise with a senior member of staff, look, your alert device is actually signaling to you that there's an issue here, you need to go and get changed. And so I'd maybe add that onto what Barbara was just saying there.
Absolutely. Anything that helps, really. Absolutely.
Okay, next one. So we've had, very nice to see, we've got lots of people online from lots of different countries around the world, and a number of people have asked, how can anyone outside the UK access the training module that you were talking about?
Unfortunately, at the moment, it's actually only available for NHS staff. But I'm working to see if we can find some sort of solution to this, because a lot of people have asked for it. So, yeah, we'll just have to see if we can make that available to other staff outside the National Health Service. Hopefully we can.
Okay, work in progress. Thank you. Next one. You mentioned that having pockets in MRI is a source of danger. Why are staff not checking them before accessing the scan room?
I know. Why are they not checking them? Time and time again, it seems that items get missed. And I've got lots of examples. I don't know why people, it's the human failing. We think we've checked things. We haven't checked things properly. If I can maybe give a couple of examples that I've heard about. There was an example where a member of the theatre staff during an anaesthetic session had been given a new design of scrubs. There was pockets at both the front and the back, whereas the normal scrubs that they wear in and out only have pockets at the front. So during an anaesthetic session, they had gone up to theatre actually to retrieve something that was required for that case, and they'd put a pair of ferrous scissors in their back pocket. When they returned to the department, they forgot all about the scissors. Now the radiographer, just as you could see from my presentation, did the right thing, and they asked all the anaesthetic staff before they were permitted to enter the scan room to retrieve their patient to check that they had nothing in their pockets. The radiographer visually attested this. She checked them and she asked them to pat themselves down, and they did. And they're also asked to verbally confirm that they've nothing in their pockets. So they said, yep, I've got nothing in my pockets. However, the person with the scissors, having completely forgotten about the back pockets, had also forgotten that she'd put a pair of scissors in there. So she was allowed into the scan room because nobody could see the pocket. She hadn't realised she had a back pocket. And it was only literally at the last minute she twigged that she felt something move at her backside, and she ran out of the scan room in shock, I have to say. So this, she narrowly averted a disaster with scissors. And I actually have lots of examples where scissors have gone into scan room by mistake. If you remember the case 2009, I think it was, in the Netherlands, where the technologist had to be rushed to theatre to remove scissors which were embedded in their forehead because an assistant had come in to help her with the patient, but with scissors, and hadn't realised. So it's so easy really to get it wrong. And I think taking the pockets away would just be one element. And, forgetfulness, it's an all too common failing. And I think it's compounded that MRI is such a complex and busy workplace. We've got lots of interactions with patients, visitors, staff, senior consultants. So it's very difficult to always keep an eye on absolutely everything. And I would say taking the pockets away would just be one element, as well as, removing as many interruptions to people's train of thought as possible too. But yeah, removing the pockets, a very small but vital element, and reducing these number of forgotten items.
Thanks, Barbara. Another question related to that one, actually. Question is, should a registered nurse be allowed to take his or her phone into Zone 4?
Into the scan room, Zone 4?
Yeah.
Why would they ever be allowed to take a phone in? Yeah, exactly. Why would they ever be allowed to take a phone in? Well, one, it would probably damage the phone. But as soon as you start to let anybody take any item in and no one else is allowed to take that item in, then a precedent is set. So no, absolutely not. You wouldn't allow anybody to take a phone into the scan room. You're trying to get rid of the things that you can't even see, but if you can obviously see a pen or a key or a lanyard, you would obviously remove that. It's just a risk you wouldn't take.
Very clear. Thank you. What exactly are, you mentioned human factors, and isn't something ending up in the scan room that shouldn't be there, isn't that just down to human error and carelessness?
Yeah, I hear this every time when an accident occurs. Oh, it's just carelessness that someone's forgotten to take that pair of scissors away or that coin, or, you know, they've taken the wrong wheelchair. But this is where the human factor comes in, because it doesn't matter how much you train staff, we are all forgetful. We are only human. Human factors is all about good safety science, bringing in the experts that look at every part of an MRI department, from the design, from the training, from the policies, from the procedures, the barriers in place, to make up for, if you like, to compensate for that human failing of forgetfulness. Now, it's already used in safety critical industries like the airline, nuclear, transport industries, and as a result, it's improved their safety records. But it seems to be rarely considered in healthcare. And I would say in healthcare it's vital, because, you know, we're trying to keep everybody safe, and regulation is so apparent, risk analysis. So as I said, we've got this ergonomic paper which is being published in radiography, and again it's the first approach, we think, of looking at the human factors approach to MRI units, with these recommendations which will likely be relevant for every MRI unit. It's just looking at what causes an incident. It is not pure forgetfulness. There are other things at play, and we need the experts in to design it as safe as can possibly be.
Barbara, only got time for a couple of questions now, but next one. No one really has the time to record incidents where items have not caused an issue, have not caused a real problem in the scan room.
Sure.
After all, they've been spotted by the technologist, we don't have time to record them.
Yeah, I can see people would say, well, it's another near miss. You know, we've spotted it, but sometimes if you're only spotting it when something is stuck to the scanner, I don't really consider that a near miss. Okay, maybe someone wasn't injured, and the equipment, you were lucky the equipment wasn't damaged. But what happens the next time? Reporting, we know it's laborious and it's time consuming, but if we don't report near misses and the actual incidents, as we know they're not being reported anyway, where an injury or damage has occurred, how can any of us learn from these incidents? An incident in your department might be happening every week in somebody else's department. And if we don't actually know what's happening or why it's happening, there's no trends. So you might have got away with it 9 times out of 10. On the 10th near miss, it's lethal. So it's learning, again, it's all about the human factors, learning how to prevent these near misses, but we have to be reporting them in the first place. And that's where the reporting categories all need to be reviewed as well, because we know that reporting, it can take sometimes half an hour to report a single incident in some cases. And quite right, staff are very, very busy. They really they can't see the need to report something where nobody has been injured. But we're not getting the trends then. We're not getting any trends identified. These same incidents are happening time and time again, and we're not learning from them. If we were to harmonise the incident reporting, it encourages reporting, and it might make analysing what's actually going on much easier. We'd be able to know the number and the type of incidents that occur, because otherwise we can't see how to identify trends. And these incident reporting investigation centres, it is their job to identify the trends and to address the issues. But if we don't have the reports, they can't address the issues because they don't see them. The incidents are hidden. It appears as if MRI is extremely safe. Now, we know that on the whole, there are millions of scans that occur. It is on the whole safe, but every incident that happens, absolutely every incident is preventable. So we need to find ways really to address these issues, and that is very, very important that people start to report the near misses that are occurring.
Thanks, Barbara. And just one more question, which actually follows on from that one, really. How do you think we can work towards an agreed UK categorisation of incidents so we can better compare rates and learnings? Do you think there should be some mandatory reporting requirement like there is for radiation?
I agree. I absolutely think that's a great question. I think that is the way. If we started to make it mandatory to report incidents, we would get a handle, if you like, on just how many incidents are occurring, what type of incident. So making it mandatory, and the first research study that I did, absolutely the radiographers, the MRI staff felt that we should be reporting more and it should be mandatory, because we really don't have a clue just the full extent of what's going on unless we make it mandatory, it appears. And it's because of those reasons we spoke about. People, workplace pressure, they don't have the time. They may not be encouraged by their managers to report anything because their managers don't understand the importance of reporting near misses. It's looking to the long term. How do we get these trends? How do we actually see what's going on? Making it mandatory would be the way forward. We know that manufacturers tend to report the incidents. They're encouraged to report the incidents, and in some cases it is mandatory for them. But for us users, it's a recommendation, and it should be mandatory, I think.
Excellent. Many thanks, Barbara, and of course, many thanks to everyone who's joined us today. Everyone will receive an email later on with a link where you can join the webinar on demand. So please do forward that on to any of your colleagues who were unable to join us for this live session. So many thanks to all, and goodbye until next time.